Hello, good evening, and welcome to today's session. We are talking about research design and methodology. We're going to make it very simple. And if you think it's very low and below the level, it is deliberate so that we get the basic ingredient, and then higher levels, we can always seek support and help. So this is just to help refresh our knowledge and then point out some key and basic things that we look out for, especially in the methods of the proposals and the methods of the dissertation. We generally will provide basic ethics, which we will cover in detail in another section, and then a general format of a research proposal and a dissertation. Then we'll look at the basic research methods and some few general guides for looking at the proposals and dissertations. So I will start with the general guide in respect to the ethics of research. Therefore, we say all proposals and dissertations that are submitted to the college should be in accordance with fundamental ethical principles. It is for academic, it is for professional practice, and we cannot compromise on the safety of participants and how well the protocol is, the science behind it, as well as the ethics. And therefore, all the rules that governs human participant research as per the Declaration of Helsinki and other international ethical guidelines for biomedical research involving human subjects is important, and the college considers that very seriously. So according to these guidelines, as trainers, as reviewers, assessors of proposals and dissertations, the basic principles, ethical principles of respect, beneficence, and justice should always be looked out for. The participant in the study must be respected, and their basic human rights should be ensured. We cannot, because of our research, disrespect or take away the rights of the participants. The research must, of course, be of benefit. If nothing at all, then do no harm, as we all know. The proposal or the current research might not directly benefit the participant, but it should benefit others in a way. Otherwise, why then do we do the research at all? What is then the rationale or justification for that? It should have some benefit. So there should be beneficence to the participant or other related target population. We might find some key or make some key observations which may improve practice and enhance the care of others who necessarily might not be the direct participant of the current or index research. And then finally, for the ethics, there should be justice, fairness, and equity. We cannot unnecessarily burden participants or get them to incur costs outside the usual service they would receive. You cannot ask a mother to come with a newborn baby outside the usual expectations. First day, Thursday, 6th, 7th day. That is the policy. You cannot ask them to come on the 5th day because you are conducting a research and you want to take blood samples 3 times within the first week. If we did that, we are not being fair to our participants. So some of these basic ones should be looked out for. Is the research going to burden the participant? Is it going to make them incur cost? It's not only about fiscal cost, but sometimes opportunity cost. Is it really necessary for them to be visiting as many times as possible, as the research is indicating? Opportunity cost is important. The mother may have other children to be taken care of. And because of our research, we cannot ask her to be coming to the hospital as frequently as we desire. So these are the elements that we always need to look out for in dissertations as well as the proposal itself. So I put in dates. We are going to have details in another module, but just for us to, as I said, it's a revision. So for a general proposal, these are elements or tenets that are important, and there may be differences depending on where you are sending it to. But for the college, the key elements are there should be a title, there should be an abstract, which should have a background, an aim, the methods, and the expected outcome. That is for the proposal. Then there should be a background that has an introduction that states the problem, what really are the issues that would be improved if this research were conducted. And then we provide a justification, rationale, or a significance of the study, indicating why should anybody care? Why should there be time spent, resources spent, and effort in going through this research? Then the background should also have research questions or hypotheses, as it were. We'll discuss this subsequently in this lecture. And then it comes with aims and objectives. Then we have the literature review. We may include in the literature review or in the background a conceptual framework, depending on what is being discussed or the subject of study. Then the proposal must also have the methods. And importantly, the methods, as we know, basic, the method should be in the future tense. And sometimes you find dissertations, not dissertation, proposals, and the methods are written in the past tense. And you are a little worried, has this research been conducted already? And those of us who sit on ethical review boards, IRBs, we tend to see these ones. And you raise question mark. Either it's copy and paste or the research has already been conducted. Because for the method of a proposal, it should be in the future tense. Then it ends with the references and other ancillary components of the abstract, which we will see in the next slide. However, for the abstract of a dissertation, it follows similar pattern with a title. The abstract is the same as that of the, similar to that of the proposal. However, in this case, the abstract would have the background, have the aim, have the methods, have the results, because now you have results and you can conclude on the result, as opposed to the proposal where you do not have results and conclusion. You can't conclude in the proposal abstract. You can only describe the expected outcome. That's a slight difference, and I believe we know this one. It's a revision, as I continue to say. The background is basically similar. However, in this case, the literature review is in more detail than the proposal. Usually, the proposal may be limited depending on the specifications, but in the work itself, the dissertation, the literature review is in more detail. The method, especially importantly, it should be in the past tense in the dissertation. And sometimes we also see in dissertations, students who then lift the methods of their proposal directly into the dissertation, and you see future tense when in fact the work has already been done. So these are key things we look out for when assessing either a proposal or a dissertation. And then the references for both are there. So just slightly putting this in context. Some ancillary components of the proposal is important. There must be a budget which will indicate the cost, and in fact must specify the justification of the cost. It is important. It is also of ethical concerns. You cannot do a simple cross-sectional survey, questionnaire-based, sample size 150, and then come up with a huge budget, as if you are conducting laboratory analysis, all that. So, and must be just, the cost must be justified. The proposal must also include the research team and the effort. In this case, we expect the team to be the candidate and the supervisors. And for the candidate, the effort should be his personal effort. Once he is committing his total time in the program on the dissertation, that should reflect. The error sometimes we see in proposals at IRBs are, we tend to make it summative. So if there are 5 people on the project, then we divide it 20%, 20%, 20%. That is not the case. When we are indicating research team and effort, it is individual over 100%. How much of each individual's time is going to be spent on the research? So it doesn't have to be summative. It doesn't have to add up to 100% when there are 5 people. One person can be 80%, another person can be 40, another can be 60, another can be 5. Each person is a sum of 100 out of 100%. How much effort are you spending? So that is also important to look out for. Then there should be a work plan schedule. That's one of the weaknesses our students tend to have. They usually do not go per the work plan, and the colleague is trying to strengthen this so that we have milestones at specific times, so that if you join the program in 3 months, you need to do A, in 6 months, you need to do B. This is shared with the candidate, this is shared with the supervisors, and both teams, the supervisor and the candidate, are then responsible for ensuring that the work plan or schedule is complied with going forward, so that we limit the times that our candidates stay in the program and some of them become career or professional residents. We want to move from that. Once they've moved into the fellowship, we ensure that they go by these milestones and we achieve the result in the optimal time that the college provides. Then there is also important to put in participant information sheets, consent forms, and assent forms. So if the study is among adults, 18 years and above, consent forms. If it is involved in children, then we know that older children need to provide assent, and these forms must be inspected and must be provided as part of the proposal submission. The proposal should also have sample data collection tools and instruments, depending on the study design and how data is going to be collected, whether it is quantitative or a qualitative type of study. Importantly, we want to see the CV of the principal investigator or the supervisor, co-supervisor, etc. That shows the involvement of the supervisor, and we know who is looking over the shoulders of the candidate. And others as may be specified depending on what the college wants. But generally, these are the elements we look out for in the proposal, and it is important all these are appropriately reflected, because it is important going through the program and doing the dissertation itself. So for the research method section of a proposal or a dissertation, this is a general guide And if we always structure it in this way and get our candidate to structure it this way, it touches on all the important and key elements that are expected in a research. There should be a clear description of the study design. We'll go into a little more detail. Then the study site must be aptly described. Then there should be a description of the study population, which then will include the inclusion and exclusion criteria. Then how many people, how many samples, how many object groups are involved? That is the sample size. And there should be an indication of how the sample size was determined. Now that we know how many, then we need to know how are they going to be recruited. Sometimes you see dissertations, and once the candidate just indicates the sample size, it is enough. No, you need to indicate how participants are going to be selected and should be described such that somebody else can conduct similar research with what we have written. That should be the principle behind our assessment. This proposal I've read, can somebody else take it and run a research with it? That should be a guiding principle for us as we review and assess our candidates. Then there should be clear definition of endpoint. What variables are going to be measured? Herein then comes what are independent variables and what are dependent variables. It is important. This should be clearly defined and then should be described how they are going to be measured, which we will do on Monday. Basic analysis plan and how you analyze data, basic ones. Now that you've explained what the independent and dependent variables, what are you going to measure, then we need to describe what instrument or tools they're going to be used to collect the information. Should be very well and clearly described. Then a detailed description of the processes, procedures involved. It's not just about describing the instrument. If you are going to measure BP, it is important to describe that you are going to use Omron 152 manufactured by so and so. It is important, so we know the instrument. But how are the records going to be taken? Are we going to measure the BP with the patient standing, reclining, or lying down? How many times are we going to measure the BP? Once, twice, thrice, and if we do it 3 times, are we taking the best 2 or are we taking the mean of those 3? These are all important elements that should be described, and these are the processes. If we are taking blood samples, we need to indicate this is going to be taken from the antecubital fossa. 3 ml of blood will be stored at this temperature and sent to the lab and will be processed within this number of hours. These are key elements that need to be looked out for. And then, as I indicated, the data analysis plan. For the proposal, all that is required is the data analysis plan, and it is very good for a quantitative study, usually to put it in a table form. It saves a lot of talking, and then we will see on Monday that basic ways of presenting this and making it easier for everybody to follow, and then the ethical consideration. So this is a very important slide that summarizes all the key elements that should be in a research method section. There may be variations depending on the type of study. Of course, if you are doing a meta-analysis, you are doing a scoping review, systematic reviews, these are variations. But by and large, these key elements should reflect in most of the research that our candidates undertake. So let's look at a few details of this. Research question and hypothesis. I just put in this to indicate that all proposals or protocols should contain a formal and explicit segment of the research questions to be studied or the research hypothesis to be tested. It is important there should be an explicit statement of the question, e.g., for descriptive and exploratory studies. And when you need to conduct an analysis to indicate whether there are relationships, whether there are associations, then you need to state a hypothesis and ensure that the methods are in a way written such that these hypotheses can be tested. And therefore, if you are doing a simple cross-sectional study where you are not doing any analytical or conducting any analysis, data analysis to assist, find association, then it's better off to state a research question and answer it. So we say a hypothesis is a statement. It's not a question about an expected relationship between one or more independent variables and one dependent variable. And therefore, there should be an element of analysis there to be able to test your hypothesis. So once the hypothesis is stated, it is important to look out for operational definitions of all the variables that have been included in the hypothesis. It is important. Let's say you are conducting a study on aging. There are different cutoffs and definitions internationally for who an older adult person is. We can say 60, we can say 65. Sometimes we can even say 50, depending on what we are doing. And therefore, for a particular research dealing with older adult, it is important that the definition of such a key item is provided operationally. That in this research, if we say older adult, they are persons 60 years and above. So I'm just giving this an example. Much as we have the liberty to operationally define key variables, it should go with science and theory. You cannot say for your research an older adult is defined as a person who is 30 years. It is not science, it is not theory. And therefore, the operational definition should meet also certain strict criteria. You can do fasting blood glucose levels. There are International Diabetes Federation, WHO, those ones, yes, you define which one you are considering, but you cannot create your own and put figures there and say, that is my operational definition. So I want us to be mindful of that. For example, as I said, hypothesis is analytic. So members of the community who receive health educational messages are more likely to go for the COVID-19 vaccine. This is a hypothesis. You can test and see. 200 people, 170 went for the vaccine. Of those 170 who went for the vaccine, how many of them had received health educational messages? You need to do some analysis to come to that association and conclude whether you can test your hypothesis. Or older adults who receive the COVID-19 vaccines have lower risk of experiencing adverse events after immunization than younger adults. We can conduct a study to determine this one. But for research question, it is exploratory, forgive me. It is exploratory or descriptive. It's not analytic. We need to correct that. It is exploratory or descriptive. The analytic is for hypothesis. Apologies for that. It should be descriptive. Why are Ghanaians hesitant in receiving the COVID-19 vaccine? This is a question, and it can provide descriptive answers. Is it due to fear of the side effect? Is it due to inadequate information on the safety profiles of the vaccines? Is it due to mistrust of the processes leading to introduction of the vaccine in Ghana? Things like that. These are research questions that you can answer without conducting any major analysis. You can provide descriptive answers to this one. So it is important when our candidates use hypotheses and when they use research questions. So it is exploratory and descriptive for the research question. Now let's look at a useful summary. Because of time, we are just using pointers to the different types of studies. The major classification that we usually use is the observational studies and then the experimental studies. For the observational, they are non-experimental, and nature usually determines the exposure. And it could be descriptive or it could be analytical. Descriptive, both the cause and effect exist, and that is what you're looking out for. Could be case report, you see one interesting case, you write on it. Case series, a number of cases pulled together, and that's how come some important clinical observations are made. Or case study, get an interesting case, you go into detail on that, and then, or you use a situation. You can write Ghana's health system or care of pediatric cancers in Ghana using the Ecole Hospital Teaching Hospital as a case study, things like that. We can do that. They are all descriptive things. Some of these descriptive ones may also have some analytical components. And therefore, we say cross-sectional studies, typically descriptive, but may also be analytical. And therefore, you can have candidates describing or writing proposals. It's basically cross-sectional studies, but they are doing some analysis. They are doing some comparisons. And therefore, these are all acceptable and should be considered by its own merit. The analytical studies, as we know, are the ones that we do. We conduct some analysis, either back into history or forward into the future. There is a time element. So we consider the descriptive studies as a typical camera, and then the analytical studies as a video recording. So for example, a child at the birthday may be very happy, hearty, and suddenly falls and be crying. If you take a picture when he's crying and you describe it that he wasn't happy throughout his party, that is not a fair reflection of what happened. But if you took a video, you will really be able to determine and judge the child's demeanor and behavior throughout the party. That's a simple, simplistic example of how these ones go. So case control is you select based on the disease. The disease has occurred, and typically you may go back into the history to find out what the risk or exposures were. Patients with certain cancers or participants with certain cancers, we take them, we take others who do not have cancers as controls, then we go back into the history to find what probably might have accounted for the development of the cancer. And then the measurement, the outcomes are different. Even how you determine sample sizes are different. Cohort study can be retrospective, can be prospective. Usually the common one is the prospective. You take a group and you take another group. This group one are the risk group. They have been exposed to a certain risk. Let's say hypertension or persons with hypertension. 120 patients with hypertension, 120 patients normotensive. And we follow them up for 3 years, 4 years, 5 years, and see how many among each group will determine chronic kidney disease or something like that. We can really determine incidence because we are looking forward. They have an exposure, and how many of them develop the disease of interest or the outcome of interest at the end of the day. Then we can calculate relative risks and assign rates that if you have this exposure, then your risk of getting this outcome is 3 times compared to those without the exposure from the start. Things like that. Those are the basic things. And we have a few more complex ones. If our candidates are minded to do, we can also support them. Nested case control, you are doing a prospective study, but within that, you have found an interesting result. You can look at that, go back and assess what the results are whilst the bigger study is still going on. Again, there are discussions that we should be amenable to accepting qualitative studies as well as systematic review. So I believe the college will discuss and take a decision on that. But these are all types of studies that provide a lot of clinical information. The big group next is the experimental studies. The investigator determines exposure under controlled conditions. Clinical trials, community trials, and sometimes quasi-experimental studies. These are all types of studies that our candidates can undertake. Sometimes the challenge is that what they are describing is in fact not what they are doing. The candidate might be doing a simple cross-sectional study with comparable groups. And because they have two groups and being compared to one another, they call it case control. That is not. So I usually tell students, if you are not sure, you describe what you are doing. Don't put a name to it right from the start. And you see all kinds of combinations. Prospective, cohort, longitudinal studies, everything is there in one study design. So we need to look at it and advise them. If you are not sure what you are doing, you describe what you are doing and then seek help so that it is put in the category that it belongs to. Longitudinal studies are also prospective studies, but usually they do not have controls. Let's say you take 175 pregnant women. At booking, you measure their HB. You do your intervention in giving hematinics, antihelminths, improving diet, sleeping and mosquito-treated nets, all that. And you follow them up. And after 6 months, you check their HBs again. That is a typical longitudinal study. You are following the same group of patients. And then in that case, you do your analysis, as it were, before and after intervention and all that. So we should be mindful. Sometimes they combine all, prospective, cohort, longitudinal, everything is there. We need to let them make it as simple and then seek advice on how the study designs are described. It is important. Another important element is the study site. I'm providing useful summaries and pointers. So what goes into the study site description? It depends usually on the objective of the study, but there is always the need to describe specifically what services or activities occur at the site. You are doing something in hematology, and all that you describe is Korle Bu Teaching Hospital that was established in 1923. It's on longitude 5° north, things like that. The important element will not be described. They won't even mention hematology clinic or where it is being done, whether it's sickle cell clinic. It's just blanket, Korle Bu General or Komfo Anokye Teaching Hospital. Specifically where the site or the study is going to be conducted is not described. It is important. We need to know the personnel, if it is a clinical study, how many consultants or specialists, how often is the clinic run, how many new cases are seen, how many old cases, at an average number of patients per week, things like that. And then the workflow and function. If it is well described, it really helps. When you tell me your sample size is 210, meanwhile, you are dealing with new cases. And then in your study site description, you are telling us the clinic runs every week, once a week. And every week, only about 7 new cases are seen. And if you just oppose it to the time frame that you have given us, is it realistic? Is it feasible? That is why it is important to provide this information when you are describing the study site. So it justifies your sample size, it justifies the feasibility of the study, and it justifies also the time element. If you say you are doing it in 6 months, will it be enough, adequate to give you the numbers, the minimum sample size you've indicated? So it is important that the key elements that should go under the study side should be described, not some of the other elements that are not crucial or critical. So description of the study side should be comprehensive enough to convince any reader or reviewer the feasibility and ability of the researcher to obtain or achieve the study objectives, as I said, obtain the minimum sample size within the specified time frame. It is important. Sometimes we do not put a lot of information under the study side description, but it is important, and these are key things we need to look out for when assessing proposals and dissertations. Participant. Now, ethics indicates we need to describe the people who take part in our research as participants, not subject. Subject is like a lord and a subject. The researcher is not lording over any of the persons involved in the study. They have equal rights, and therefore it's better respondents, participant is conventionally preferred. So describe clearly who the study participants are. This is also important. If we don't do that, then people then will tend to indicate that I'm going to do a purposive sampling because this and my people are dealing with prescription practices. Of course, prescription practices in the health setting or hospital setting, your study participant usually will be doctors, prescribers, pharmacists, or if they are nurse prescribers, yes. And this must be clearly described. And therefore, once you describe this, when you get to your sample selection of participants, you won't tell anybody that you are doing purposive sampling because you have already described the group. So amongst the group, the target group, how are you selecting them? Then you can use a probability sampling method, anything, to select amongst the doctors, to select among the pharmacists, to select among the nurses. Usually students don't do the description very well to describe exactly who the participants are. And because of that, the major attributes and characteristics that qualify somebody to be a participant in the study are missing or get lost. We need to look out for this. It also helps in the appropriate description of the inclusion and exclusion criteria. I would like to highlight here that inclusion and exclusion criteria are not just opposites of each other, as our students or candidates are wont of doing sometimes. Even the study title is Cervical Cancer Screening Among Adult Women 18 years and above in a district hospital in Ghana. And then you go into the exclusion criteria, and the exclusion criteria is females less than 18 years. That is not an exclusion criteria. You've already stated the inclusion criteria is 18 years and above. And therefore, what we look out for is for a woman 18 years and above, what will qualify her to be part of your study, or what will disqualify her from being part of your study? That is what the exclusion and inclusion criteria look at. And therefore, you can say that a woman 18 years and above who is pregnant, that is a good exclusion criteria. Or you are dealing with cervical cancer and your exclusion criteria is men are excluded. Those ones are unacceptable, and at the level of our candidates, we expect them not to do that. But if you look critically, the statement of inclusion and exclusion criteria are always problematic. So we always say these are redundant. What have been captured by the inclusion criteria is also then turned in the opposite direction as the exclusion criteria, and that is not correct. Usually, it is preferred concise description or in simple bullet points. So it's easy for everybody, but sometimes the whole paragraph describing inclusion criteria and it's all over the place. So we can always advise that it makes it easier, simple for reading. How large should a study be? Too large a sample means waste of resources. Too simple a sample diminishes the utility of the results. And therefore, there should be an optimal minimum that will give you what is required. In animal experiments, the minimum is the number. We don't have sample sizes for that. In qualitative studies, we say when you rate saturation, that there are new schools of thought. And even when it's of suggesting some numbers, otherwise, how do you do your budget if you want to get to saturation to know the numbers? So these are things that strict sample sizes are not. But when you are doing quantitative studies, clinical trials, things like that, the sample size is critical. And it is chosen based on the objective of the study and the outcomes, the level of confidence with which you would like to estimate the population parameter. Some of these ones we will explain on Monday. The level of the acceptable error, and then in consideration with the available resources. You sometimes do not need to conjure figures, but there are considerations with resources, and there are scientific acceptable ways of managing the sample size so that it is scientifically acceptable and can give you the estimate of the population parameter. Some persons, some candidates who want to play smart, they would tell you, my confidence level is 95, but my margin of error is dividing by 0.7 so that it becomes smaller. And then you see the inconsistencies in there. And these are things that are not acceptable. So we need to look carefully at the sample size, and we can always ask for support in this area. Generally, I put this one there. This is the most common one we use for prevalence study, but this is not a one size fits all. It's not a magic bullet. It doesn't solve all the problems. That every study that you see uses the Cochrane or modified Cochrane's formula. No, it is important we look at this carefully. And as I said, there is always room to ask for support from peers and colleagues in this regard. Sometimes there may be the need for a finite population correction. You are dealing with children with Burkitt's lymphoma. There are only as many children with Burkitt's lymphoma you can get. And therefore, when you calculate your sample size and you are getting 250, and in fact, over the last 5 years, the whole hospital hasn't got that, that sample determination needs to be corrected. What it means simply is that if I were using the whole population, my sample size was going to be 250. Now, the maximum possible I have is 125. How much of the 125 proportionally should I select to be able to precisely determine the population parameter statistically? That is what the meaning is, so that you can correct it and still make meaningful deductions from the limited numbers. But we shouldn't allow candidates to use time elements that, oh, I'm doing 3 months, and for the last historical records, the hospital have only this many. So since I'm working 3 months, this is as many that I can get. Why is 3 months? Why not 6 months? Why not 8 months? So those ones are difficult to justify. And as reviewers, we need to look at those ones. They are not very strong element for saying that I need a finite population correction factor. Student candidates tend to like that, and we need to look at that whenever they use that. There are standard sample size determining formulae for different types of studies, depending on the study outcome. If it is a rate, is it a single rate, or they are comparing rates? Comparing 2 rates, comparing 3 rates, or a single proportion, or comparing proportions? Is it a mean? Is it a single mean or comparing mean? Are these case control studies? There are standard sample size determination that could or must be used. And therefore, the prevalence or cross-sectional determining formula should not be the one that is always used for every type of study. Brief reasons why samples are important. I won't go through it detail. We know that in terms of cost, time, and effort, and sometimes you do not necessarily have to involve every element in order to be able to make statistical inferences. In some studies, you may destroy items, you may use drugs. It is important to minimize this as much as possible without compromising the accuracy and utility of the study results. So sample size determination is very, very important. And it's usually impractical or impossible to measure an entire population all the time. And therefore, there is always the need to do sampling. How then do we do sampling? This is just a little summary. We cannot, of course, teach some participant selection in detail within this time. But the basic summary is that the sampling of participant selection could be probability sampling and non-probability sampling. If we are going to make statistical inferences, associations, then it is important we do a probability sampling so that the whatever errors are systematically distributed. It's randomly distributed, as it were. That's what I should say. So simple random sampling is a basic form of selecting subject. It is tedious, time-consuming, but it gives a lot of strength because it provides every element within the target population a chance of being selected. It could be through balloting, computer-generated numbers, things like that. And sometimes at the clinic, there are ways we can do these ones. Systematic sampling is where we partition the sample by dividing the target population over the sample that we intend to obtain. And then we get the partition, which is the K, as we call it, the skip interval. And then once you've gotten the K, the key element of note is that you need to then select the first participant within the first partition. So if the K is 5, it means the first partition is 5. And therefore, you need to select a number from 1, 2, 3, 4, 5 randomly. And then you select every, if it's third, then you select every third number. What we can also do to help our candidates is if they are doing clinical settings, what they can do is they can specify that for thoroughness and accuracy of what I want to do, the maximum number of subject or participant I will select every day is 5 or 10. And therefore, if I go to the clinic, depending on how many eligible folders or patients I select, I divide by 5 and get my K. So systematic sampling can very well be conducted in the clinical setting if we are able to just indicate some key element, and then we can do that. Stratified sampling is when the population is heterogeneous and we need to make them homogeneous. Then we can do the selection using any of the above method, the simple random sampling or the systematic. Cluster is when you are dealing with clusters, groups. It's better for that than for individual items or elements. So you do a clustering and you select a cluster. The point of note is that once a cluster has been selected, every element in the cluster is eligible. You don't go back within a cluster and go and use another probability sampling to select members from the cluster. So you see therein will be a grave disadvantage, depending on how you select a cluster. If you go to a village, like my students are wont of doing when they go to the community diagnosis, they will select areas of the community where there are new buildings, houses, thinking that those people may probably be able to answer their questionnaires better, language will not be a problem. And then they come and tell you 97% of the buildings or houses in the village community were cement or have iron roofing, which in fact may be a small portion of the village community. That is one of the classical challenges with cluster sampling, and we need to always be mindful of that. The multi-stage sampling is when you are combining different sampling strategies, and it's also acceptable. What needs to be done is at each stage, whatever sampling method you are using needs to be described clearly. I am working in phases. You describe your methods in phases. In phase 1, we are going to use simple random sampling to select dates. In phase 2, because it's A, B, C, D, we are doing systematic sampling. In phase 3, we do that, things like that, and it is clearly acceptable. The non-probability sampling are limited. However, sometimes that's the only way you can do or conduct a research. And therefore, you cannot make inferences. Both the internal and especially the external validity of the results finding, you cannot generalize it. When you have, in fact, like the journalists do, they go to the market, ask 2-3 tomato sellers, and then they make their conclusions. That is convenient sampling. You can't generalize that. So quota sampling is the non-probability form of the stratified sampling. You have your quota, you go in, you select. You don't use any probability method. Snowballing is easily useful for conditions that are probably stigmatized under the carpet things. People are not openly willing to tell you. And therefore you identify one, and the person tells you the next, and then you get the number you want. So there is this table that summarizes it. I'm not going to go through it. I believe we will have this recording and we also have the presentation. So we can go through when to use each of the methods here. It's gone in a little detail. What are the advantages and what are the disadvantages? This is a useful table you can go back and look at, so it helps in our ability to review the work of our candidate. We've done it also for the non-probability methods. Very similar. When to use it, what are the advantages, what are the disadvantages? The next point is definition of endpoint. Study outcomes are very important, and we need to clearly describe, indicate the type of data we are going to collect and about which variables are we going to measure. We need to define what are our cases, what are our controls if we are doing that. And if we are doing comparable groups, it doesn't necessarily make them cases and controls. And we need to advise our candidates well. That it could be the experimental group or the non-experimental group. But once you use cases and controls, more often than not, they tend to then go and say this is a case control study, which in fact is not. It is a pure cross-sectional study with comparable groups. So we need to clearly look at the definition that are used. Are these real cases? Are these real controls? And if they are cases and controls, what are the ratios? Is it 1:2? Is that the same thing that was used in the determination of the sample size? Or this is merely comparison of two groups in a cross-sectional setting? Then independent variables. We know the independent ones are the ones we are measuring about the outcome of interest. So the dependent variable could be outcome of delivery. Healthy baby, everything fine at birth. So mother giving birth to a healthy baby. So what are the factors that will contribute to all this? Those will be the independent factors. Antenatal clinic attendance, early booking, doing all the screening tests that are important, the preventive things, and doing all that. All those ones, measuring the BPs, checking the HB, all those ones will be the independent factors. So the dependent factors are also some maybe described as the what? The response, the outcome, the dependent. Then the independent, maybe the predictive, the covariates, all the different terms are used to describe these ones sometimes, but the predominantly used ones are the independent and the dependent variables. Then control, exposure, treatment, outcomes. This should be clearly described. What are the exposure variables? Treatment, outcomes. And the key point I want to note is confounders. How do we determine confounders, and at what level? Is it at data collection level? Is it at analysis level? Some of these ones, we may go beyond the level of this, but we can always ask for support. So I want to clearly explain briefly. Confounding factor. We say it's an extraneous variable that correlates directly or inversely with both the dependent variable and the independent variable. I want to give you, I always do that. I want to give you a practical, funny example, but it is important. It keeps the definition in your mind. We want to conduct a study on liver cancer among church goers, attendants. Liver cancer, church goers. Church goers midweek and then Sunday. At the end of the project research, we found that those who come Wednesday, Sunday have reduced risk of liver cancer. And therefore we conclude that being prayerful and attending church more often will protect against liver cancer. However, alcohol use, in this case, influences or can lead to liver cancer. Alcohol use by people over the weekend, that's why I said it's funny, may also mean that people overindulge Friday, Saturday, so they can't even go to church on Sunday. So the only time they go to church is Wednesday. But in our consideration, we didn't consider alcohol at all. And alcohol is, in this case, a classical confounding factor. I just want to use this basic, simple, funny example to show what confounders can do. I believe it is clear and interesting to consider that. I already mentioned conceptual and operational definitions, which should be sound in theory and science, but should clearly indicate what the researcher is talking about. How do we collect data for research? It could be through observation, just observing, could be through experiment, observation, clinical examination, history taking, all those ones. Then experiment through discussions. There are different means of discussions. We can do the panel discussion. Typical example is, I don't know whether they still show it, Mancomo or type of Oprah Winfrey type of show. A few key people or persons will then have a discussion, and then the audience will ask questions or do a discussion. Then we also have the focus group discussion, where it is more moderated. We have a moderator, we have a recorder, and then things are done, unlike an open discussion where others can dominate and others will not want to speak. So there are different ways of conducting the discussion, and once the candidate indicates the discussion, they need to describe exactly which type of discussion they are talking about and what are the advantages. Interviews are also important. When conducting interviews, it is important, the do's and the don'ts. And then we can use questionnaire and other tools. Sometimes clearly, students, our candidates always want to say they are using questionnaires, when in fact, they are clearly using a checklist or an abstraction form. The patient is going to theater. You can't even question or talk to the patient. All that you are doing is extracting information from the anesthetic notes and the surgeon's notes. This can be an abstraction form. You are just abstracting information. But you see, they always write, use a questionnaire-based survey, things like that. So we need to use the appropriate tool to take the appropriate type of information. Then we can do medical records review as well. I want to speak a little on questionnaire design, since that is commonly used by our candidate. The questionnaire should, sometimes when we are reviewing, we don't pay attention to the questionnaire. And I believe we shouldn't do that. We look at the questionnaire and see whether it answers or it is able to provide answers to the objective as stated by the candidate or researcher. It's important. Questionnaire should be short. The questionnaire should not contain two main themes. It should contain one single theme every time. We say it shouldn't be double barrel. Flippant questions should not be asked, and questions that embarrass the participant should be avoided as much as possible. If it needs to be asked, then probably we can push it to the very end of the, so that by that time you have gained rapport or confidence of the participant. Otherwise, it puts them off. Leading questions. Some of the questionnaires are clearly leading, and we should look at the type of questionnaire that will elicit the response that we need. So these are the type of instrument I've said. Questionnaire, it's either self or interviewer administered. Then the observation, we can use checklist, visual, clinical, physical examination. Experiment could be through laboratory investigations or physical field investigation. Interviews could be personal, direct, face-to-face, or through telephone or mails. And we should, once our candidate opt to use any of this, we should clearly let them know the disadvantages of these ones. And then records review, panel discussion, as I indicated, and a combination of all these instruments. So all these are acceptable means of collecting information. It shouldn't be only questionnaire based all the time. We should encourage diversity a little among some of the things they do. A few guidelines for developing the study instrument. The instrument should be based on the theoretical framework that has been selected for the study, which means the candidate should have read. The literature review is important so that they know the subject and therefore the right questions are asked. That the tool should be valid and reliable. It should measure what it purports to measure. And then it should be repeatable. When you use it today and you use it tomorrow, it should give you comparable results. It should be suitable for its function and appropriate to test the hypothesis or the question. And the instrument should be free of bias. And therefore, if we do not go through the questionnaire as reviewers, how then do we come out with all this? So I will urge, it is important. Let's look at the questionnaire. Sometimes some of the questions are completely unnecessary. It makes it long, and then ways of improving the questionnaire. So improving data quality, we need to pre-test the instrument. It is always important. Pre-testing helps to improve the validity and the responsiveness of the tool to the set objective. And then if we need to do re-interviews, because we found that there are too many missing variables, train the interviewers and supervisors for data collection. This is for the supervisors on the ground, not us. Students, candidates who may have persons overseeing others collecting data for them. It is so important. The person is doing a certain surgical procedure and determining blood loss, but is using residents, medical officers, consultants. These are things that create problems for the data collection. And therefore, once you train your interviewers well, some of this will be avoided. And then all the data quality checks, how data is handled, how it is kept, how we enter data, how we deal with missing data, they are all important elements to consider. Ethical issues, as I mentioned initially, is always important. Privacy refers to persons. and to their interests in controlling access to others and to themselves. It is sometimes difficult on the open ward when other patients can overhear everything that is being said about the next patient. And you are also conducting research and interviewing patients in the open, and everything they are saying, others are hearing. They might not volunteer to give you all the information or the correct information. So privacy is important. Confidentiality refers to the data itself. How are you keeping the data? So we need to ensure our candidates do not become flippant with the way they handle people's information. You go and collect information, they call you, there is a case. Then you leave all the folders, everything lying on the nurse's table. Everybody comes and read, oh, okay, Mr. A has this condition. That is not fair to your patient. You can't do that. So we need to insist our candidates know how to keep data confidential and people's information so we can continue to get information from our patient and the human subjects that we easily use for our studies. Animal experiments, we don't do much of that in the college, but it has its own procedures and what to do and what not to do. You cannot kill 10 rats when in fact you can use 3 to do that. So these are key things. If any candidate is mindful, maybe basic sciences, wants to do some animal experiment, then that may require a little more support, even at the supervisor's level, to be able to do that. We've mentioned all this. It's important to include the informed consent. Clearly indicate benefit and risk. Sometimes our candidates are only interested in the physical harm or risk, but they forget about the psychological, the social, and the economic factors that may become discomforting to the participant. It is important. Risk is not only physical, not the pain, but there may be other elements that needs to be included, and this must be included in the submission. So finally, references. The college has its style, and that is what must be followed and must be consistent throughout. And it should contain all the sources cited in the text. Sometimes they indicate references in the text, but they are not in the list of references. And therefore, we cannot gloss over the references as well. It is important when we are reviewing to look at the references, how they've been cited and how they've been used. It should be consistent, and all the references should be checked against the original information. There is always a difference between a reference and a bibliography. Our students tend to over-reference. They use several references, 150, 180, and you ask yourself, if you are going by the strict terms of a reference, you need to have read the text and use it in your dissertation. So can you tell me that you have reviewed all these 150 citations that you've indicated? It is not bibliography. Otherwise, we would state it as a bibliography, which is a list of all the sources you use to generate your ideas about the topic, including those you cited, as well as those you did not. That's for textbook and others. But for scientific research dissertation, we use the ones, you see one single sentence. Malaria is prevalent in Africa. And then there are 5, 6 references. That's what sometimes our candidates do. That should not be encouraged. It should be concise. We, of course, cannot give minimum numbers, but reasonable referencing and having read the information is useful than putting everything in there. So the key message is, this is not a prescriptive guide. This is just a revision to highlight some of the key things we look out for. And then our trainers will need to consult other tests and discipline-specific requirements in assessing proposals and dissertation. And again, and most importantly, discussion with peers who have specific skill is encouraged. It builds our skills. So we should always be ready to ask for support if there are some things that are not in our core area of practice or discipline. So thank you very much, and we will have time for discussion.